Welcome, everyone, to today's webinar, The Evolution of Pharmacy as Health Systems' Innovative Partner. On behalf of Becker's Healthcare, thank you so much for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you do not see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to welcome today's moderator, Nicole Fauché, President of Clearway Health. Nicole, thank you so much for being here today, and I'll now turn the floor over to you to jump into today's discussion.
Thank you, Mariah, and thank you to Becker's for hosting us today to talk about the innovation and the evolution of specialty pharmacy. As we talk today, I want to also say thank you to our two panelists that will be joining. We'll do introductions here in just a moment. But to kick us off, the contribution of an involved specialty pharmacy program on the overall success of a health system can easily be seen through the experiences and stories that my esteemed colleagues are going to discuss with us today. Elevating the pharmacy as a member of the integrated care team has shown to improve patient compliance, adherence and engagement, and improve clinical outcomes, as well as decreasing the cost of care. Today, we will explore many high-functioning specialty pharmacy teams, their journey and characteristics. Our panelists will react and respond to questions designed to help highlight the need for a deliberate and an intentional strategy to help transition any specialty pharmacy from a cost center to materially supporting health systems in their performance clinically and financially. Please join me in welcoming our two panelists. First, Alistair Bell, Executive Vice President and Chief Strategy Officer for Boston Medical Center Health System. He has spent a great deal of time growing and accelerating the program in Boston and is really the backbone for our program here at Clearway Health. So thank you, Alistair, for joining us. And Jigar Thakur joins us from Oklahoma University Health, an organization that has a long history of much excellence in the state of Oklahoma, and he has had great success in creating a program for his patients and community in Oklahoma City. So thank you, Jigar, for joining us. So as we kick off today, it's really important that we talk about the idea that many organizations are looking at growing their specialty pharmacy program, and many are at various stages of growing that program and evaluating what type of contribution a specialty pharmacy program can make to their health system. So what I'd like to start with is Alistair, if you would, just what prompted you at BMC to look at investing in a specialty pharmacy program?
Hi, Nicole, and thanks for having me on the panel. So I've got to rewind the clock here a little bit because we're probably going back 8 or 10 years at this point. So if you can imagine what it was like back then, what we were looking at was with the rise of specialty drugs as a category, we kind of saw pretty distinct opportunities across patient outcomes, provider experience, and financial improvement for our health system. So, on the patient side, these transformative therapies were emerging in ever-increasing numbers, sometimes offering the potential for cure in the case of hepatitis C, but also need to work much harder to support patients in accessing those medications and adhering to courses of therapy. For providers, higher cost medicines were resulting in pretty significant administrative burdens from payers who were, I think, probably appropriately cautious about opening the spigot on what were really high cost drugs. And so we saw an opportunity as a system to support our providers engaging with our patients. And then last up, as an organization, we saw an opportunity to really achieve a step change in our financial performance. Margins on drugs eligible in 340B program have always been high on a percentage terms, but really with the advent of very high cost specialty drugs, that sort of turned into the financial opportunity grew much larger, and kind of went from focusing on capturing large volumes of prescriptions onto actually a much more focused set of programs targeted at specific patients, specific doctors, and specific therapies. And so those things kind of combined to drive our investment in specialty pharmacy, our journey then afterwards at BMC, and then ultimately, I think a lot of the challenges in realizing the value drove us to found a Clearway, which you're now leading forward, Nicole.
Thank you. It has been great to see so much of what the program has provided for BMC. And Jigar, in your role, you really embarked on this journey very early in your tenure at OU Health. Just kind of walk us through what you saw there and why this was so important to you early in joining the organization.
Yeah, definitely. Thank you, Nicole, and thank you to Becker's as well. I will say that since Alistair's journey was 10 years ago, that just means I'm younger because ours is more recent. But I think Alistair covered it. Very similar experience for us at OU Health. We knew that the FDA is approving these specialty drugs at a much more rapid pace, now than they did historically. It represents really a $400 billion industry. These drugs we know are curative or they delay these, diseases. And so a lot of innovation has come out from pharma. And really for our health system, we really saw it truly as an obligation to our patient population, right? We said we need to have a specialty pharmacy program that's comprehensive because these patients are actually getting these medications. Our providers are writing for these medications. Our clinic staff is dealing with all of those medications. So we really saw it as an obligation that you have to have a comprehensive program to be able to meet those provider needs, the patient needs, the complexity, the financials associated with it, and really to carry out a program that improves the cost of care, and really helps these patients adhere to their medications, and really help them actually achieve what these medications are intended to do, right? So whether it's a cure, whether it's delay their disease. So yeah, we mainly saw it as an obligation, and we really saw it as really a no-brainer, for us and at OU Health to make it a top strategic priority that was actually presented to our board, and the investment that we would make around this priority. And really when we got those involved at the board level, the executive C-suite, and everyone involved, we really found it very important for us to actually execute on what we wanted with this investment.
That is exciting to hear. It's funny, I think that we would all say at this point some of these actions or taking this journey is a bit of a no-brainer. Part of it's because we've seen the success on this path together. So I do think that as you hear more through our conversation today, the overall quality impact, the financial and operational impact becomes just very obvious. Changing gears a little bit, but kind of in line with what you're just talking about, the comprehensive nature, the successes I've seen really tie back to how apparently clear it is that there are many, many roles that are required to help make a specialty pharmacy or pharmacy program successful. And Jigar, I'll kind of start with you here on this side, but you kind of alluded to this as you answered the last question, but outside of maybe perhaps some of the obvious team members, like who else have you had to recruit at OU Health to help really make sure that this remains a priority?
Right. No, this is a great point. I think the simple answer is definitely not just pharmacy, right? So I think a lot of people, when they think about specialty pharmacy or this, comprehensive specialty pharmacy program, the first thing that normally comes to mind is pharmacy, but you have to involve a wide variety of stakeholders, right? So the first one that comes to mind is the facilities group. So we always worked hand in hand with our facilities group to design not only our specialty pharmacy and kind of build those out, but to also help with our clinic designs and kind of our business development efforts. So they've not only been integrated and work with us, but they actually help us now give us ideas on how we can, increase the impact of this program. We also involved our ambulatory leadership, right? So getting the leaders of all the clinics, super involved, along with the providers and the staff. We really took the approach of, while we wanted to do this as a whole system for our health system, we really took the approach of designing the program at each of the clinics with the end user in mind, right? So we really involved the providers at those individual clinics and the staff, because each of the clinics have different needs, right? Whether it's, for example, our reproductive health clinic has very different needs from the pharmacy program than our oncology clinics do, right? So all of these clinics really require a different level of support. They also require the clinical pharmacy program to be really designed differently to meet their needs as well. So I'll go back to the same examples. Our oncology program utilizes board-certified oncology pharmacists to really plan and manage all of the treatments. They actually are the ones writing up the treatment plans. Whereas our reproductive health, they require more of a support from assisting these patients with the financial assistance piece, right? Because a lot of these reproductive health meds, although these patients have insurance, a lot of times are not covered by insurance. So we needed an approach where it was more geared towards patient assistance, the financial assistance there, as well as all the support necessary. So you really have to kind of, go at each clinic and design it specifically to the clinic needs. But again, to answer your question, really a wide variety of stakeholders and across the organization. It's important to have that buy-in, because you're going to get that ongoing support from that buy-in that you're going to need in the future.
Mm-hmm. Yeah, very good point. The reproductive health program, I think, is one of the more creative population groups serving through this type of program, and it's been great to see some of the success stories and patient appreciation there. And also for you, your population is a little bit different, and you even serve a broader group related to ACO. Do you see any other additional team members or groups that you've worked with that are really critical to the success of the program at BMC?
Yeah, I think Jigger's covered it. I think maybe what I leave you with is there's obviously the clinical operational leadership. There are also sort of somewhat counterintuitive parts of the healthcare system get dragged into this as well. As you look at total opportunity and ability to capture specialty prescriptions within your system. So you might find yourself spending a decent amount of time with the legal team around what space is 340B eligible space or not, so that you can kind of unlock opportunity. You might spend a fair amount of time with your clinical data warehouse people as you try to gather quality data on particular drug prescriptions, so that you can make the case that to drug manufacturers to actually allow your specialty pharmacy to be in network. I think probably the one thing though that I would really, and it's sort of a consequence of this sort of multidisciplinary approach that is required, is this really does require executive level leadership. My experience, those that have done it well, and I would include BMC in that category, it becomes a top 5 topic within the health system, where CMO, COO, CFO, the CEO all understand this. The board understands the risks and the challenges of realizing this opportunity, and you're working through every part of the organization to try to both take advantage of the opportunity, but also sort of infuse it into how the organization works. And I don't, Jigger said it nicely at the beginning, achieving success goes far beyond the pharmacy operation. And, and all too often, when we've worked with some kind of local counterparts, you find efforts stalled because they're trying to work out the whole complicated equation from within the pharmacy operation. And so part of it is pulling it up a level from that and trying to look at all of the things that need to kind of come together within a system.
Mm-hmm. Yeah. I think if it's seen as a pharmacy project versus a system or initiative that really can impact so many areas, it would certainly be limited in its opportunity to grow and contribute. As from a specialty pharmacy, the program, we're often serving patients with the most complex diagnosis, sometimes comorbidities, many, many times challenged through various social determinants of health. Have there been particular service lines or patient populations that have been most positively impacted, or those that have been most meaningful to the health system? Alistair, I think that knowing that population that BMC serves, it'd be great just to start with you here. And I know there's just been some great stories within the community.
Yeah, I think, really any service line with specialty meds actually benefits from, can be positively impacted by a specialty pharmacy program, because it brings a degree of focus around the patient and the provider experience that really sort of enhances outcomes. I would say early on, we saw particular impact in our patients suffering HIV, where access to medication resulted in pretty significant improvements in the management of their disease. Hepatitis C in the early days also proved really impactful. Early on, the side effect profile of Sovaldi was so significant that many patients would have multiple runs at trying to complete a course of therapy. We found actually when we sort of aligned the pharmacy team alongside the clinical team, that the programmatic supports we were able to provide, contacting patients, following up with them during the course of their therapy, then led us to go to, I think we were around maybe 40% completion of a course, up to over 90% were completing their Sovaldi course. And it was so markedly different from others that local insurers actually started approaching us to ask us what we were doing. Because there's this almost counterintuitive thing where we were actually helping people stay on specialty medications, but from their standpoint, they were seeing that as actually lower specialty drug spend, because patients were just taking one run at therapy, not 3 or 4 or 5 attempts to try to, with $1,000 a pill medications. And so we've seen it really translated pretty huge impacts on how patients experience their care and their ability to take full advantage of the medications that they're being prescribed.
Yeah, I think that hearing the insurance or the payer's response to the program is always very interesting, because I think there's the idea that this increases utilization or cost, and in the long run, you actually see the improvement, which is that's a good thing to see. Jigar, from your side, you've already shared a little bit about reproductive health and the different clinics, the oncology care. Are there any additional areas that you've seen benefit that you'd like to share with the group?
Yeah, I will. I'll add, OU Health is a safety net provider within this state, right? The only academic health system within the state, also the only integrated academic health system. So I think just based on that patient population we serve, the impact that I've seen specialty pharmacy make, just like Alistair said, it's been in all of our specialties, but one in particular really comes to mind is our Medicaid patients, right? So we actually are doing something interesting too. I like Alistair's example of the payers noticing. So these are not just commercial payers, but obviously the Medicaid governmental payers are noticing this as well. So we actually worked with our Oklahoma Medicaid agency to really talk to them. Look, we're providing not only an embedded pharmacist, but we're providing all these additional services to these patients, Medicaid patients that are coming into our clinics, and making sure that even when they're discharged from the clinic, that even when they're home, we're having these, visits with them or phone calls with them and following up on their adherence to medications. And based on all of the work we presented to them, they thought it was going to make a significant impact in the total cost of care for these patients. So they decided to actually collaborate with us, and we're actually participating in a pilot program over a year with them, where we're going to be tracking, through another platform as well. We're going to be tracking not only the different interventions where, our specialty pharmacy program and our pharmacy staff is having with these patients, but also tracking the total cost of care, no matter where that Medicaid patient goes because of the data that's collected in Oklahoma Medicaid. So we're actually looking at what the clinical outcome improvements are and what the reductions in things like ER visits are, right? And you're able to easily track it for this population because it's all of the data goes, all of those transactions go to Oklahoma Medicaid, right? So we partnered with them, and we're going to see what this 1 year, kind of value-based arrangement really results in, whether it's a shared savings between OU Health as well as Medicaid, again, to focus on that total cost of care reduction, which is something that you don't normally think about, when you're actually looking into this revenue-generating opportunity, right, of specialty pharmacy. So I think it's a really unique example of the different things that you could do, when you have the right partnerships, when you have the right comprehensive approach, instead of just focusing kind of on a small effort of improving your specialty pharmacy capture.
Yeah, I think it's unique these days to find areas that have revenue generating opportunity that to the same degree impact clinical care. And so this is a really great success story. I also think listening to what you're doing in the state of Oklahoma with Medicaid and the pharmaceutical data or the prescription data wouldn't be new data they could mine and look for to track some of this, but the interaction of the pharmacy team as a part of the care team really changes that dynamic quite a bit. So it'll be interesting to see as you kind of go down that path, really what the story looks like. So switching gears just a little bit, they're really, at a time now where physicians and providers at various levels are tired. We hear a lot about burnout. We're coming out, or maybe we can say we're coming out of a pandemic. But it's interesting that a high-functioning specialty pharmacy team can really alleviate some of the burdens on providers and really impact their satisfaction. Jigar, I'd love to start with you here. I mean, what do you hear from providers, or how has your program helped support providers, and what's their feedback to you?
Yeah, thank you. This is definitely a timely question. I think we all know that the provider experience really has a lot to do with the staffing and the resources that they get in order to do the work that they're trying to do, right, in treating their patients. So I think generally the industry is usually aware of, I would say now that, there's in these specialty pharmacy programs, there's you're putting in either a technician or a liaison that's embedded in the clinic to kind of take some of that workload off of the clinic staff, right, to do the prior auths, things like that. You're also putting in, I mentioned, the pharmacist and integrating them within the healthcare delivery team, right? So figuring out what does the provider team need to enhance the delivery of care, what kind of support they need to actually really be able to efficiently see the patients where the provider is needed versus the things that a pharmacist can do. These highly trained pharmacists are able to do a lot of different aspects of what a provider does in the clinic as well, right? So we've noticed that the providers in our health system and in other health systems have really enjoyed that collaboration with the pharmacists, with the liaisons, and that's also helped their, clinic staff. But what I was going to add to this is, I think some of that people are usually aware of, what I just mentioned with the pharmacist and liaison, but at OU, we're actually trying to do a little bit, something a little bit different as well. Because of these shortages, right? The clinics are seeing kind of staffing shortages just like the hospitals are seeing, and those shortages are continuing. They haven't really improved post some of the, onset of the pandemic. Effects are still there, and so they haven't really improved. And so we're actually exploring the idea of having our pharmacy team not only do the, prior auths and the clinical care delivery that they're able to do, but even exploring other interesting options. Can they do some patient intake? Can they actually look at those med lists that, medical assistants or nurses or providers spend a lot of time on, even in the clinic setting, asking the patients, are you on these meds? Are you still on these meds? Which ones are you not on, or what doses? So all of that work that goes in, really, you don't need a nurse or a medical assistant or a provider to have to do that, right? So we're trying to see if our specialty pharmacy program can actually take over some of these different aspects of workload that is really, really burdensome in the clinic, right? So doing what we can to kind of assist our partners in the clinic really has been interesting. You know, people are open to pharmacies even input in this now, right? Because if we went with this idea in the past, they probably would have looked at us strangely, right? But now that they know that what the specialty pharmacy team already has been doing in the clinic, they've really bought into, okay, these guys are able to do a lot more than we thought they're able to do. So they're really open to these different types of innovative approaches or solutions within the clinic setting, and it's really leading to greater and greater provider satisfaction, which is crucial, especially at this time.
I think that sometimes change comes with a little skepticism, you know, giving up some of the work, making sure it's done to the quality that they like. But I think we've all seen that once the physicians and their staff see the work that the liaison teams do to support the patients, and then they really trust and come to depend upon them. And I think you've seen the same, Alistair, at BMC, Craig.
Yeah, I think that's right. You know, our providers love our pharmacy program. I mean, I think for many of the reasons that Jigar outlined, and you know, it's not always a straightforward path. I mean, you do have to sort of win people over to it, and so how you approach particular clinical areas. I think, you know, for us even early, this sounds almost ridiculous now, but even the idea of like, well, was our pharmacy set up in such a way that it could appropriately handle, like, say, an HIV patient's medications? You know, there's a lot of, both on the patient side and on the provider side, tentativeness around converting, if you like, into like a hospital-based pharmacy, and, you know, are you ready? And I think so, you know, we kind of won over providers. You know, I think initially it was like more administrative and pharmacist level support, you know, authorizations for medications, that type of thing at the beginning, and really kind of somewhat like, as Jigar mentioned, evolved into pharmacy becoming much more of an integrated part of the care team, where they were kind of taking on other roles and really functioning at the top of their license. Because, you know, really within the pharmacist and pharmacy workforce, you have an incredibly talented workforce that I think is oftentimes underdeployed relative to like where their license is. And so, you know, how can people be involved in shepherding people through even writing prescriptions on behalf of physicians at, you know, at points. I think there's a lot of further opportunity to be explored there. I think the last thing I'd say is that, like, what we found was like many of the specialties that were prescribing these special, really high value medications were not specialties that were, if you like, typically in a health system would typically be considered a quote unquote high margin specialty. So high margin specialties might have historically been considered things like orthopedic surgery or cardiac surgery or neurosurgery, neurology, those type of service lines. Whereas, so I think that the advent and then engagement on the financial aspect of the 340B program then kind of just ended up with different levels of resourcing being drawn into different service lines and supporting practice level investments that might have been more borderline, actually, historically actually started to have a different financial outlook, if you like, within the overall, health system economic model. Even to the point, for example, at BMC, we've looked at, our access in certain specialties and actually deliberately expanded and supported new physician hires in certain areas, because we know that actually while the if you like the fee-for-service business such that it is for an individual doctor may not look particularly great, actually when you combine it with the financial equation around the specialty pharmacy, it actually starts to look a lot different, as a system perspective. So what that has evolved to being is then much more robust programming, in some sort of service lines which typically have had less investment than others, and the expansion and honestly better ability to meet patient demand, which I think for many of the providers in those specialties has also felt sort of overwhelming. Like they just have like very long waits to get in and see them. And so I think it sort of opened up whole areas of medicine that sort of previously had been in a more kind of financially sort of constrained position, within health systems.
Mm-hmm. I think there's, certainly no question that for this program to really be successful, you have to have the providers buy-in, the clinical leadership buy-in, and seeing how both your organizations have done that and what it's meant in all the different ways you both have described has really been one of the game-changing parts of the program itself. Now, no great story or opportunity comes without some challenges, and certainly there are inherent challenges with initiating and executing a strategy like this. This is also unique because we have external challenges that we continue to face related to 340B, access issues, manufacturer actions that have been taken recently. So please feel free to take this in any number of directions. But Alistair, from your standpoint, what kind of challenges or obstacles, planned or unplanned, really were the ones that you'd want to highlight as it relates to sort of embarking on this kind of program, or where you spent some of your focus?
Yeah, and thanks, Nicole. I think, so I maybe sort of make two categories of comment, and I'm sure Drigo will expand much beyond. So like on the surface of it, it sounds like sort of writing a script and sending it to your pharmacy doesn't sound the most complicated thing to do. But really, I would say like one of the things we really wrestled with on like our overall journey was just the sheer complexity in the program. For prescribers practicing in non-eligible space, drug access and interacting with manufacturers, like an incredibly, almost absurdly high bar on compliance, within the program. And so, like, to list just a few, but there are just like many, and that combined with then the investments that you were having to make with this sort of looming specter on, would the 340B program persist? For whom might it persist? A sort of overall kind of regulatory uncertainty, put it that way, I think was just like actually quite challenging to navigate. The second is more of, I would say, maybe a comment on organizational behavior and mindset. One of the sort of challenges that one can, and I think we sort of at different points sort of fell into this trap, was that the program itself became a victim of its success. Where you start the program, it takes a lot to kind of get going. There's a lot of complexity. It's actually easy to feel like you're doing really well from a clinical standpoint, from a revenue growth, for example, in your pharmacy. You might see like your revenue might double, like from year to year. That would not be an unusual outcome. And one of the challenges then is you sort of get sort of lulled into like, oh, well, this is going well. And partly what we found ourselves doing a lot, which really sort of accelerated our growth, was constantly focusing on the total opportunity, not what we had done last year and how we might improve from there. And so it's almost like a mindset standpoint of, okay, well, we doubled the script capture, and our revenue went from A to B, but it's like keeping focused on like, what percentage of the total prescription capture were you actually achieving? And sometimes when we asked that question, we found we'd gone from like 30% capture to 50% capture, which is still pretty good, but actually is leaving a substantial amount of both financial value and then associated clinical and other impact on the table. And so I think that, you have to sort of both handle like the complexity of the program, but I would say have a sort of a single-minded focus on what your total opportunity is. And partly, I think when we sort of sought to establish Clearway Health, it was trying to shorten the learning curve, if you like, and allow provider systems to kind of more quickly like learn all of those things and have that sort of focus on the total opportunity for day one. Because many of the changes that you have to make as you go along a value capture approach actually take quite a long time to execute. Like if you want to convert some space to be 340B eligible space, that might have like a year to 15 months kind of turnaround time to like actually go to get that sort of set up. If you want to gain certain drug access from manufacturers, that some of that has like a long lead time. And so I think what we sort of found ourselves wrestling with were more challenges. And I think what I'm hoping, Clearway can help people with is actually seeing through the journey a lot more and making a lot more decisions up front that then shape a much faster kind of value capture curve than we went on at BMC, which was still pretty steep, but I would say relatively more gradual than it really needed to be if I had the time again.
So you're saying expect more always. Is that what you're telling
Yep.
everybody?
Even as an example, Nicole, on a year-to-year basis, think about budgeting on a year-to-year basis. How much growth should you budget? And it's like, well, the specialty pharmacy drug category expands at least 10% every year. So at minimum, at baseline, you should be budgeting like a 10% increase. And so there's a sort of and that is very different than how you would think about budgeting for most other things, like actually within a health system, which might be much more gradual unless you're doing some significant initiative of some sort.
Absolutely. Yeah, there's few areas where you would expect 10% plus growth within the health system, like you can in a program such as this. So Jigar, from your standpoint, I know we've looked at a lot of different things. We've talked about different challenges. I know you've evaluated many within your space. Anything unexpected or expected within challenges in growing the program that you'd like to share?
Yeah, I think on this one, Alistair took all the good points, so I won't be repetitive. But one of the things that I'll be very specific with the example I've encountered. So Alistair's absolutely right. It's a very complex program, right? I've worked in other health systems, other large integrated health systems where we've initiated the specialty pharmacy program development. But even with the experience that a chief pharmacy officer can bring to the table to develop that, I think the complexity is there. And that's one of the reasons I'm an advocate of, partnering with someone like Clearway Health to actually accelerate that development, right? I think it's all about the timing. Just as Alistair said, it's all about the total opportunity, and the timing of how quickly you do this is a key point. But one of the specific examples of the struggles that we've encountered is really the hospital rev cycle piece, right? So hospital rev cycle, if you think about it, and clinic rev cycle, they're very different than the specialty pharmacy revenue cycle, right? So looking at the AR, the accounts receivable, looking at the aging, looking at if you're actually getting paid what you think you're getting paid. I mean, you're basically, when you're having this type of a program, you're running pretty much of a company within a company. And when it develops quickly, one of the things that we encountered is, we knew how much revenue we were making. We know what the receivables are, but having like your hospital finance team or your clinic finance team actually take care of the pharmacy finance, right? The specialty pharmacy finance becomes a pretty big struggle that is really unexpected, even at the CFO level, right? So I think what we're doing, and this is not a challenge that we've actually overcome yet, we're in the process of handling and overcoming this barrier, but what we're really doing here is, kind of figuring out what dedicated support we need. Is it a finance director within the pharmacy? Is it a rev cycle analyst as well? And not really thinking small about the investment you make in this area, right? So I think, people try to loop it in with hospital and clinic, but this is a very different line of business, done very differently. And so we're really thinking of having kind of like a separate financial team, pretty comprehensive financial team. We already have a couple members on it, but we're even thinking of expanding it further to ensure that we can overcome that barrier as that program continues to grow. So I think that was, I'm sure the audience would find that interesting as something unique that tends to happen is you have to really plan for that journey, as Alistair said, ahead of time. So I think, instead of, being reactive or kind of figuring this out later on as you go along the journey, it is much better to have a partner to kind of plan these things ahead of time.
You know, Jigger, you're making me smile. Actually, you're reminding me of that comment of like, you know, that one of the early challenges is that like actually it can lead to a pretty seismic shift in your P&L.
Right.
And I remember early on actually being kind of asked to explain, you know, a 300% variance in the outpatient drug budget, you know, and how this cost, which were all like, it's a large cost, was sinking our system, you know, and then gradually, like it sort of, I think, dawned on the room that actually there was a 40% on average margin attached to every one of the drugs, and in fact, like we'd actually just added, you know, X tens of millions of dollars of contribution margin as well back into the system. But it's sort of one of those things of like it just, you know, it just takes people a while to adapt to sort of just how quick and the magnitude of the impact that actually a program like this, you know, done well can have on, you know, an organization's financial performance.
Yeah, it certainly isn't linear, at least not at first. It's pretty exponential. And you're right. I think that transition from, again, we said a little bit earlier, a cost center sort of point of view to one that actually generates revenue and margins that are very material is very something to sort of prepare for. So I think we've seen that across the board. I don't think that's a unique experience in any of the organizations that we've worked with. So I think that's one that everyone should definitely take home. Sweet. So Jigger, for you here, I'll give this one to you just specifically. And what we've seen, when you see this type of success that you all have been describing, there is a lot of attention that then focuses on pharmacy and pharmacy leadership, and suspect that it changes your presence, or even perhaps, you know, this idea of seat at the table with a leadership team. What is some advice you would give to other pharmacy leaders as it relates to this sort of impact to their role and or at all from your perspective?
Yeah, no, this is something that pharmacy leaders are always seeking as well. I hear, you know, I go to a lot of meetings with chief pharmacy officers nationally, and one of their biggest, you know, complaint is that, you know, the hospital system doesn't actually give us that seat at the table to make those strategic decisions. Some that Alistair also mentioned, you know, and doesn't have that seat at the table. But when you do this, when you have this type of impact, or when you're, you know, implementing a program like this, I think people do start recognizing, and we've definitely seen that here at OU Health, really recognizing what kind of value the pharmacy team brings to the table. Not only financially, I think we focused on the financials a lot, but even the outcomes piece or the provider and staff satisfaction. So one of the things that we're doing to actually really track that value that we're providing, instead of just, you know, claiming it's there, is, you know, there's most organizations have organizational goals, right? For patient satisfaction, employee engagement, and then looking at some of the clinical metrics and quality improvement efforts, right? So I think all organizations have those same types of buckets of goals that they're looking at. The pharmacy program really has to be a significant partner in tracking like what your impact is within those buckets, right? Within those goals. So we've done a great job here at OU. We've outlined what our dashboard is on a monthly basis, where, you know, what is our, you know, pharmacy team member having an impact, for example, on the HCAHPS questions, right? So there's med management related questions on HCAHPS. So now that we have this pharmacy person within the clinic or within the hospital, even on the inpatient setting, right, embedded within the care delivery model, you know, what actual impact are they having on those 4 medication related questions that are within the survey, just as an example. And then what financial impact are each of these clinics having? So we break it out by clinics, as Alistair mentioned, so you really recognize, you know, the full value of the patient population being treated there, where in the past you may not have actually recognized that. So let's say your organization was in an environment where you actually had a big population of patients that needed neurology care. You may have, you know, your health system may actually not be extending itself to provide that care. You know, they may have a few providers or a couple providers, but your population's needs are very different in that area. So now what this program does, it's really proving the value that you're bringing to the table financially. So then if your population has that need, now your health system can actually hire other providers and actually meet that need of the population that is needing this kind of care, right? So we're in each of these buckets, basically, whether it's the financial or the clinical outcomes or the satisfaction, like I mentioned, we're actually tracking. We have interventions that we're tracking on a monthly basis and populating that on our dashboard so that we can continue to prove that it's not only limited to financial impact, but we have impact on outcomes, on really the value of care delivery that's being provided, as well as the satisfaction within the clinics that we're in versus the clinics we're not in, right? So there's all kinds of things that you can start doing to really get back at the true value that you're providing to the health system.
Absolutely. I mean, just hearing what you're speaking and going beyond the quality measures, right? We're beyond meds to bed sort of quality measures. We're looking at big ways that pharmacy is contributing to the overall patient experience and the outcomes associated. So that's very exciting. Okay, I'm going to reserve one question for after we take some questions. We have some really great questions from the audience. We're going to pause here for just a moment, and I'm going to ask each of you a few questions specifically. So the first one I'm going to start with, I know that both of the organizations that are on the call here today, BMC and OU Health, have spent a lot of time looking at some of the activities like the manufacturer blocking related to contract pharmacy and the ESP program and the request to submit data. Many organizations have been evaluating this for months now, and some have made some decisions. What process did your organizations go through related to data sharing and its impact, both financially or just on your overall decision-making process? Jigger, I'll start with you first, because I know there's been a lot of discussion in this space.
Yeah, this is a great question. I think collectively, this is another thing that we discussed at a national meeting with a lot of pharmacy officers. I think we knew the collective opinion of the community initially was that we don't want to submit this data, to these ESP vendors, right? But then your contract pharmacy opportunity is really being blocked when you don't do that, right? So I think we're still in the process of kind of exploring that, and we have started sharing in a limited fashion, for certain pharmaceuticals or certain classes of treatment. But we haven't done that comprehensively. So this is one of those things that I think the opinion is changing over time in terms of we're going to have to do this. But I will say this: I think this question also still kind of misses the greater point of what we're emphasizing here, right? You still want to integrate the care of this patient within your health system. It's only when you're kind of blocked out from being able to service that patient that this patient goes to a contract pharmacy to begin with, right? So, they're going to a 340B contract pharmacy based on a payer requirement or PBM requirement. And that's actually what we're trying to get away from by doing the work we're doing, right? We're trying to integrate that patient's clinical care within the health system, because we feel that if they do go externally, their care becomes not only fragmented, but you're not able to bring that comprehensive approach that you want to bring to these patients. So, things like we talked about already, the financial assistance, the patient financial assistance that may be needed. If they can't access their care in an external pharmacy, your providers may not even hear about that, right? I mean, I think the industry is very well aware of how many times patients can't afford medications, so they don't pick up the medication. And then they have, adverse consequences to their health based on that. So I think, that approach is good to figure out and be efficient at, but the greater approach and the greater opportunity to really focus on is trying as much as possible to integrate the care within your organization. There's a lot of different strategies to do that too, and this is one of the things that adds to the complexity that we just talked about of a specialty pharmacy program, right? It's not just capturing the medication. Sometimes it's related to improving access to those medications, or working with payers like Alistair mentioned, or to open up that access. So there's a lot of strategies that I think need to be focused on first before really considering like the data submission and other things as part of your core strategy.
Very good. Thank you. Alistair, anything you want to add to that?
Yeah, I don't think so. I think one, Jigger is I will offer the floor to Jigger on that specific topic. I do think that you know, the 340B program as a whole and what it supports. You know, I think on the one hand, it's hard to see that being rolled back in a very material way. And I think we've had some recent rulings that have been quite favorable in that regard. And legislatively, like, more is made of this than I think is really practically going to happen, because, you know, there's I've had conversations with HHS around, you know, there's a hospital in every single part of the country, in every legislative district that has some contribution from the 340B program for the most part. I do think, though, however, I think what Jigger's emphasizing, which is the role of health systems in actually embedding specialty pharmacy in their operations and pulling this in and relying less on contract relationships. Yes, from a financial standpoint, but much more from a care integration and how you actually interact with patients standpoint. I think that is a far more robust position from which to defend the program and the impact that it has. And so I think sort of some of those, I think you're right, Jigger, like some of the issues around data submission or other, which are sort of like picking at sort of, I would say, weaknesses in the way that some people take advantage of the program at the moment, start to become less relevant the more that systems have actually chosen to like actually fully integrate and embed the pharmacy programming within their core operations. And so I would, I guess, for the audience, encourage folks to really look at that and don't just look at the data part or whatever, but look at what you're doing yourself and how you're making an overall kind of argument for why you should have the program, and really joining the dots, as I think both Jigger and I have, I think, attempted to do, between both the financial side of the program, but also the real benefits and advantages that it has in multiple ways for patients and providers.
Very good. Okay, so the next two questions are going to be targeted to one of you, so be prepared. Tough ones, okay? So, Alistair, I'm going to give you this first one. You have alluded to this, but there's a question here from Catherine. I'm going to reword it a little bit, but we talked about this idea of targeting populations or targeting specialties around the idea of, you know, how you grow a program. Could you provide some insights back, again, with BMC starting, about why perhaps certain programs were started in certain clinics, or whether or not there was any sort of rhyme or reason to how the program started with particular specialties? And what?
Yeah,
and,
sure.
And
I mean, yeah. So I'll start by saying, you know, how and where you choose to initially focus. We took a very data-driven approach, and so we did look at the entire opportunity and then really identify a few areas which were going to, you know, drive both the greatest clinical and financial value. When you look at something like, for example, hepatitis C and the sort of Sovaldi journey and Harvoni, you know, subsequently, that started off with, just to give you a sense of how that emerged as both a clinical opportunity and a business development opportunity at the same time. It started off with, you know, a few clinicians, GI docs, writing a few scripts for hepatitis C patients. We knew that the actual prevalence of hepatitis C was much greater in the community, and that we were barely scratching the surface of engaging people to kind of cure their disease within the health system. So it started off with kind of gradual expansion of provider capacity within the clinic, and then associated filling of medications. We then went back and actually spoke at our medical executive committee about universal screening through our emergency department of every patient coming through our emergency department for hepatitis C. And then linked people that we were identifying as testing positive into treatment pathways then further built out the capacity there. And so it sort of went from sort of I would say a targeted opportunity assessment of current state, and then said, well, didn't look at capturing that initial opportunity, but then also saying, well, where is the market overall in a particular specialty, and is there actually an opportunity that we aren't capturing out there because we aren't serving a whole group of patients? And so sort of step one, capture what was there. Step two was then kind of look at actual very explicit growth of service lines in areas where we know that we're under addressing a clinical need in the community. And so for example, now when we look at our hospital growth from year to year, as most systems do, we actually find ourselves looking at the intersection of specialty pharmacy and particular specialties, and actually deliberately are adding and growing specialties where that we see untapped opportunity in the community to address their healthcare needs with specialty medications. And so it's kind of gone from kind of a specialty capture into much more of a business and strategic financial and volume and clinical planning exercise, of which pharmacy is kind of more of a downstream component.
Very good. Thank you. I do think there is a targeted approach to help, one, facilitate the program and sort of have the stickiness for it to expand further within the organization. With only a couple of minutes left, there are many great questions, and I just want to say to the audience, thank you for providing them. We will capture those and are prepared to answer those if you would like to reach out to us following this program. They span from, various ways we're working with payers, certain types of treatment centers like hemophilia, HIV, and also really how we go about, or how these organizations have gone about remaining engaged with patients and enrolling patients in types of programs. I think these are all really critical questions, and we'd love to have a chance to address them for each of you. But as we wrap up the call here, I just want to give each of our panelists a moment to provide for this group. One of the greatest assets we have in healthcare is being able to share this type of information, sharing lessons learned. And so what I would love to ask both you, Alistair and Jigar, is what advice, if you were to have this audience sort of leaving with a piece of advice that you would give them from your journey, what advice would you offer to hospitals or health systems who are considering truly investing in especially pharmacy at all, or accelerating the program they have? And Alistair, I'll start with you, if you don't mind.
Sure. Okay. So, and I'll, at the risk of mildly repeating myself here, so 3 practical bits of advice. 1, executive level sponsorship. The program obviously has to be anchored in pharmacy, but it's an organizational endeavor that spans clinical and operational leadership. So you need executive level sponsorship. 2, focus on the total opportunity. Don't get distracted by good growth year on year. Like, focus on the total opportunity, and it's usually much, much larger than you think, and you should capture it much, much faster than you believe possible. And then 3, I would say get a partner. If you're at an early stage, at a low level of percentage capture, or even kind of midway along, I would really encourage you to look at a partner, to accelerate your journey. And as a shameless plug for Clearway, I would just say sort of look for one that has very strong values and is very clinically anchored, as I think. And, as we established Clearway, it was very much a goal that, they be carrying forth how we think about things at Boston Medical Center to other in a very kind of mission-oriented way. And so those would be exec sponsor, focus on total opportunity, and get a partner. Very
good. Thank you, Alistair. Jigar, in the final moments, what would you give for advice?
Within the last 30 seconds. So I agree with Alistair. I think Clearway Health, that we did an RFP, and we got a lot of responses, and we saw Clearway really as the winner. We got our university involved, our university provost involved, as well as our entire health system, because we're a large academic health system. And we saw that, just as Alistair mentioned, we saw them as, a health system oriented company, right? That was focused just not only on the revenues, but also on the clinical component, really providing the things that we need to actually do for this care delivery that we're trying to improve on. And so we saw a clear winner there. But the key point I would say is really don't think small about this effort. Don't just focus on building the physical pharmacies or just embedding the staff. It's a much more comprehensive approach, and time is really key, right? Accelerating this approach and implementing it very, much more comprehensively than you initially think about is really the key thing here. So.
Very good. Thank you both. I think when you said clear winner and Clearway, there was no pun intended in that, I don't think, right? Maybe. Okay. Thank you both for joining. Truly, your insights, I think, have been very helpful. I think it's probably created some more questions for our audience to continue to think about. So thank you for your time. And Mariah, I'll hand it back to you.
Yes, well, that is all the time we have for today. I want to thank Nicole, Alistair, and Jigger for an excellent presentation, and Clearway Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.